In order to make the diagnosis of sarcoidosis, you need to have symptoms, physical exam findings that are consistent with sarcoidosis. This picture here is a patient with lupus pernio, which is a characteristic rash, usually around the nose, around the cheeks. It's almost diagnostic for sarcoidosis. So if you see something like this, this supports the diagnosis of sarcoidosis. But it doesn't have to come in the form of skin disease. Patients can have eye problems. As many of you know, you can have uveitis. This is a person with anterior uveitis. And, their manifestations of disease can come in this format. In addition to having symptoms and physical exam findings that are consistent with sarcoidosis, you need to have supporting data that is consistent with sarcoidosis. And supporting data can come in all different forms. Classically, it comes in the form of an X-ray. If you guys can see this picture here, this is what we call a stage 1 X-ray, patient with bilateral hilar adenopathy, which basically means that the lymph nodes in the chest are swollen, and you can see the arrows pointing to those swollen lymph nodes. This is very characteristic of sarcoidosis, and when you see this, it supports the diagnosis. But once again, even if you have symptoms and physical findings and you have a chest X-ray that is supportive of the diagnosis, in most cases, this is not enough to diagnose sarcoidosis. In most cases of sarcoidosis, you need a biopsy, and a biopsy of an organ that shows these collection of immune cells called granulomas. And granulomas are really sort of the immune system response to an unknown foreign substance or substances. In addition to having symptoms and physical findings, supporting data, and a biopsy that shows granulomas, sarcoidosis remains what we call a diagnosis of exclusion, meaning that we have to make sure that all of these findings, and in particular the granulomas that we see, are not because of anything else other than sarcoidosis. And we say not because we say other than sarcoidosis, what we mean is there isn't a cause. We don't know why the granulomas are there. But there are many different reasons people get granulomas, from bacteria to fungus to foreign bodies in the skin. All of these things can cause granulomas, and we have to do our due diligence to make sure that none of those things are causing the granulomas that we see. As many of you know, sarcoidosis can basically affect any organ, but it more commonly affects certain organs. And this is a chart that sort of gives you an overview of the organs that can be affected in sarcoidosis and the frequency at which those organs are affected. And you can see that the lungs, for example, are involved in 95% of cases. The skin is involved in approximately 20 or 25% of cases. Patients have lymph node involvement in about 15% of cases, and we can go through all of the rest, but you get the idea that we need to determine, when we're assessing the sarcoidosis patient, we need to determine which organs are involved. It's really, really important to emphasize and focus on this slide because it's important. Organ involvement is not the same as organ activity. And just because an organ is involved doesn't necessarily mean that it needs to be treated. An organ involved means that there's evidence of sarcoidosis in the organ. And there's a difference between involvement of an organ and active disease within an organ. Active disease is defined by inflammation from granulomas, which impairs the function of the organ. And in some cases, active disease is also defined by poor quality of life, which we measure by quality of life questionnaires. So just to step back from the lecture that I've given so far, the first thing that we always want to do is make sure that the diagnosis is correct. And there is a rigorous process that we need to go through in order to be sure that the diagnosis is correct. We don't want to label somebody as having sarcoidosis when they don't. That's the first step. Once we are comfortable with the diagnosis, we need to define which organs are involved. And that just means that for a variety of different tests, we see evidence of sarcoidosis in a variety of organs. Once again, just because we see the sarcoidosis in these organs doesn't necessarily mean that treatment is indicated. Treatment is only indicated when there is activity or inflammation in the organ that impairs the function of the organ. It makes sense that we can define organ dysfunction or malfunction, however you want to call it, malfunction, dysfunction of an organ differently depending on the organ that we're looking at. So if, for example, we look at the organ system here in this list, we look at sinuses and we say, are the sinuses involved? Okay, maybe they are. We have a CAT scan of the sinuses that shows that, there's some swelling in the sinuses, there's congestion, there's sinusitis, but we really want to know, does this patient need to have those sinuses treated? And the way that we know that is, one, by the patient's symptoms. Are they complaining of congestion, crusting, nosebleeds? And do they have an abnormal exam? And that exam is generally done by an ear, nose, and throat doctor who may or may not order a CT scan of the sinuses. So that's sort of how we assess the sinuses. How do we assess the eyes? Of course, patients have to have symptoms: blurred vision, light sensitivity, painful red eyes. They also need to be evaluated by an ophthalmologist. And the ophthalmologist exam, a slit light exam, is absolutely critical in determining whether somebody has inflammation in their eyes that needs to be treated. Ancillary testing such as CAT scans and MRIs may also be needed, but the bulk of examination by the ophthalmologist is really key. The heart is a very important organ that we need to assess. Of course, patients with cardiac sarcoidosis may have symptoms of chest pain, palpitations, lightheadedness, fainting. And we want to assess that organ by an electrocardiogram, a Holter monitor, perhaps an echo, but most importantly are two really important advanced cardiac imaging tests known as cardiac MRI and PET scan. These tests are sort of the gold standard for diagnosis of cardiac sarcoidosis. Most of you are familiar with evaluation of the lungs. Patients with activity in the lungs may have shortness of breath, cough, wheeze, and most importantly, they may have abnormal pulmonary function tests. Yes, they also may have abnormal imaging, but in my experience and in my opinion, the imaging is the least important of all of these things. The symptoms of the patient and the pulmonary function tests are much more important in telling us whether the lungs are not working properly and whether they need to be treated. The liver, we can look at blood tests. We can also look at imaging tests to assess. Same is true of the spleen. When it comes to neurologic sarcoidosis, symptoms are a must. Patients must also have an abnormal physical exam, and all of the symptoms and the abnormal physical exam are supported by imaging. The gold standard, again, is MRI of the brain or spine. Many of you might have suffered from high calcium levels in the blood. It's very easy to assess calcium levels in the blood with a simple blood test. Of course, we must determine that the high calcium in the blood is because of sarcoidosis and not because of other reasons. But that is the measurement by which we use to determine whether treatment is indicated. Patients may or may not have symptoms depending on the level of the calcium in the blood and the rapidity at which the high calcium level occurred.